He who wishes to be a surgeon must first go to war. You know, that quote from Hippocrates, it really lands differently when you start digging into conflict surgery, doesn't it?
It absolutely does. It points straight to this, well, this ancient link between warfare and surgical progress. It's stark.
Yeah, millennia of learning under fire. Like
Ah.
that Edwin Smith papyrus, what, 1600 BCE?
Yeah.
The oldest known text on trauma surgery. Incredible.
That connection's fundamental. I mean, the history of battlefield surgery is kind of the history of surgery itself in many ways. So many things we take for granted now.
Like triage.
Exactly. Triage systems, organized casualty care. People like Larry, during the Napoleonic Wars, they basically hammered out these principles in the middle of chaos.
Providing complex care amidst, well, utter chaos. That seems to be the enduring challenge.
It really is.
And that's exactly what this deep dive is about, conflict surgery. Now, obviously, there's overlap with civilian trauma. A bad injury is a bad injury.
Sure, some principles carry over.
But the material you shared makes it crystal clear. War surgery is its own beast. It's not just more trauma.
Precisely. It's distinct. Unique demands, unique constraints you just don't see in civilian settings usually. You can't just copy and paste protocols.
So our mission here, pulling straight from the source material, is to really go deep. Understand the core principles, the specific, often brutal injury patterns, and, well, grapple with the huge challenges involved.
Yeah.
We want to get this, understand it like the elite professionals do.
Okay, let's do it.
So let's unpack that. What makes war surgery fundamentally different? What are those key contrasts?
I'd say the environment is probably the most obvious starting point. It's often incredibly austere.
Right. Not your typical city hospital.
Not even close. Even with long-term deployments, you might get sophisticated Role 3 hospitals eventually, but you're always fighting logistics, supply lines, personnel limits. Those advanced diagnostics or therapies you rely on back home might just not be there.
You operate with what you've got, where you are. Simple as that.
Essentially, yes. And then there's the danger. It's inherently hostile.
Medical teams aren't safe behind the lines.
No, they're often moving with the fighting forces, integrated. Think physician-led resuscitation teams, forward surgical teams. They're pushing closer to the point of injury.
Which means workforce protection becomes a massive issue itself.
A critical priority, absolutely. The threat is constant, and that leads directly into the injury patterns themselves.
How so?
Modern weapons, they deliver incredible amounts of energy. The tissue destruction, it's just on a different scale compared to most civilian trauma. Even, high-speed car crashes. It's often far worse.
Which immediately flips the switch to a mass casualty situation.
Almost by definition. War is a mass casualty event. You get surges of severely injured patients, often all at once, and that forces a completely different mindset.
You can't treat everyone the same way you would normally.
No. The guiding principle shifts. It becomes, do the best for the most, not everything for everyone. In a civilian trauma bay, you throw everything at each patient. In conflict, you have to prioritize resources, time, interventions. It's about maximizing overall survival for the group. Tough calls.
A difficult but necessary reality. And the care itself, you mentioned, is staged.
Yes, almost always. Patients move through different levels, different echelons of care. We apply damage control principles along the way. It requires really careful planning, coordination, communication, all the way through the chain.
Okay, so that sets the scene, the environment, the operational constraints. Now, let's get into the framework that governs all this. This is where it gets really interesting, ethically and legally.
Right. International Humanitarian Law, IHL. This is the rule book, essentially, derived from things like the Geneva and Hague Conventions.
And it lays out rights and duties for medical personnel. The core mandate, highlighted in the material, seems unequivocal. Treat based only on medical need.
Absolutely, period. No discrimination. Nationality, race, religion, politics, side they fought, none of it matters. You treat the worst injured first. Full stop.
Which means treating your own forces and enemy combatants.
Correct. And that has real practical consequences for planning.
How so?
Well, your evacuation plan, your definitive care pathway,
Yeah.
it might have to change. You might not be able to send an enemy combatant to certain national hospitals, for example. So you rely on host nation facilities or other arrangements, which affects later stages of care.
And you see the ethical weight in that example, given doing a really complex limb salvage like revascularization on a local patient in a country with 0 rehab facilities.
Exactly. You might save the limb surgically, but what's the actual long-term functional outcome going to be without that essential follow-up? It's a profound dilemma you face in these environments.
Thinking beyond just the OR table.
You have to. And IHL also protects medical personnel and facilities. Their non-combatants shouldn't be targeted.
The reality of modern conflict, asymmetric warfare.
It makes it incredibly challenging. Identifying combatants, ensuring facilities aren't misused, it's tough. So security for medical teams isn't just a nice to have, it's absolutely essential. High priority.
The ideal versus the reality on the ground.
Requires robust security planning, always.
Okay, so given all that, the tough environment, the danger, mass casualties, the ethical rules, how is care actually structured, let's talk about these medical support roles.
Right. This tiered system, it's designed to integrate with military operations, be adaptable. The names might differ slightly between nations, but the basic functions are the same. Provide essential treatment, manage supply, and evacuate casualties effectively through the system.
Starting right at the front, Role 1.
Role 1 is your unit-level care, closest to the action. Think primary healthcare, enhanced first aid, basic triage, resuscitation, stabilization. What they can actually do varies a lot, depends on the unit size, the medic's training.
Then moving back a step, Role 2.
Role 2 is intermediate. It receives casualties from Role 1. Here you get more advanced resuscitation, shock treatment, and critically, the ability to perform damage control surgery, or DCS. They can also hold patients for a limited time before evacuation or return to duty.
Okay, DCS capability is key there. Then Role 3, the hospital.
Role 3 is your deployed hospital. Multi-specialty surgical teams, primary surgery, diagnostic support like X-ray, CT maybe. In long conflicts, these can become quite sophisticated, almost like fixed hospitals.
And the final step, Role 4.
Role 4 is definitive care, usually back home or maybe a major allied nation's facility. This is for the really complex stuff, the long-term care, rehabilitation things that just can't be done or take too long, closer to the front.
And the critical takeaway seems to be that this whole structure, what capabilities are where, it's all dictated by the military operation itself.
Absolutely. The medical plan has to mirror the operational plan. Needs are predicted based on the mission.
Getting casualties through these roles efficiently sounds paramount, which brings us to medical evacuation, medevac.
Right, medevac. Specifically, the movement and care during movement within the conflict zone, point of injury to Role 1, Role 1 to Role 2, and so on.
And the big game changer mentioned is aeromedical evacuation. Helicopters, fixed-wing planes.
Huge impact. Dramatically cuts down the time to get critical patients to surgery.
But you can't just throw someone on a helicopter, right?
Definitely not. They need to be stabilized enough for the flight mode and duration. Airway and breathing have to be secure. That's non-negotiable.
All tubes, secured IVs, drains.
Everything locked down. And altitude changes can cause barotrauma, pressure injury in the chest. So for high-risk patients, maybe prophylactic chest tubes before a long flight. Plus, preventing hypothermia is vital blankets, warmers.
And the evacuation platforms themselves vary hugely.
From basic transport to essentially flying ICUs, knowing what's available, the timelines, the distances, that's all major planning factors. Evacuation isn't just a taxi service, it's another phase of care.
Okay, let's talk about that famous phrase, the golden hour.
Ah, yes, the golden hour. That initial period after injury where intervention makes the biggest difference. Its precise origins are debated, maybe not a strict 60 minutes, but the principle, universally understood. Time is critical.
And the military data shows most deaths happen early, pre-hospital.
Often very soon after wounding, yes. Which reinforces the need for rapid transport to surgery. Better outcomes correlate strongly with shorter times to surgical care.
So the strategies focus on shrinking that time.
Either shrink the time, faster transport, push surgical teams forward, use telemedicine perhaps, or try to lengthen that golden window.
Lengthen it how?
Through better pre-hospital care. Novel hemorrhage control techniques right at the point of injury, maybe pre-hospital blood products, starting resuscitation minutes after wounding, not waiting an hour.
So shorten the clock or slow it down. Both vital.
Both are key strategies for tackling severe deployed trauma.
Now let's really get into the types of injuries, because the battlefield has changed and so have the patterns.
The data here is really striking. Historically, looking at U.S. forces, infantry got more penetrating wounds, air and naval crews more blunt trauma. Predictable enough.
But recent conflicts, Iraq, Afghanistan, show a big shift compared to, say, Vietnam or WWII.
A huge shift. Head and neck injuries are way more common now. Thoracic and extremity injuries, less so.
And the likely reason?
Almost certainly body armor. It's protecting the torso and limbs effectively, but leaves the head and neck relatively more exposed, particularly to blast effects.
Which leads us to the massive change, the mechanism of injury. Explosions.
Explosions are now the dominant cause of injury and death, far surpassing bullets. The stats from Iraq and Afghanistan are stark. Something like 80% of injuries were from explosions.
That's a fundamental change from past wars.
Completely different. And the signature weapon driving this is the improvised explosive device, the IED.
Why IEDs?
They're cheap, relatively easy to make, and unfortunately, the knowledge is widespread. They are likely to remain a major threat because of that accessibility.
And they range from simple mines to complex bombs.
Right, roadside bombs, suicide vests, and those particularly nasty EFPs, explosively formed projectiles. They use the blast to turn a metal plate into a high-velocity missile, basically. Punches through armor, causes horrific injuries inside vehicles.
So given these high-energy, often blast-driven injuries, what are the guiding principles for surgeons?
Well, the grim reality is battlefield death is usually very early catastrophic brain injury, massive hemorrhage, or it's late from infection. Some early injuries are just unsurvivable. Prevention is key where possible.
But for those who can be saved?
It's all about hemorrhage control. That is the absolute cornerstone of military trauma care right from the point of injury. Stop the bleeding.
Ow.
Tourniquets are fundamental for catastrophic limb bleeds, for bleeding inside the torso that you can't compress. Well, that has a very poor prognosis. Endovascular techniques are being looked at, but they're not routine yet.
And this focus on stamping bleeding leads straight to damage control surgery.
Exactly.
Oh.
DCS. The immediate goals are stop major hemorrhage, remove dead or grossly contaminated tissue, and limit further contamination. You also consider early limb salvage revascularization, shunts, fasciotomy, but only if the patient is physiologically stable enough. You don't risk the patient's life for a limb if they're crashing.
Let's delve deeper into DCS. It came from doing shorter operations on unstable patients, right?
Pretty much. Abbreviated laparotomies initially. Now it's a formalized approach for really complex trauma. The core idea is simple but powerful. Restore physiology over anatomy.
Not aiming for perfect repair first time around.
No. You're fixing the life-threatening physiological problems, the bleeding, the acidosis, the hypothermia caused by the injury. The perfect anatomical repair comes later.
And it's done in phases.
Typically, yes. Phase 1. Recognize the patient needs DCS, severe injury, unstable physiology. Rapid assessment, anesthesia, warming, get them to the OR fast.
Phase 2.
Yeah.
The initial surgery.
Correct. Quick laparotomy, for example. Control the bleeding packing, maybe ligating vessels, control contamination staple off bowel maybe, temporary wound closure. Speed and control of immediate threats are key.
Phase 3. Recovery time.
Move them to the ICU. Intensive resuscitation continues. Correct the coagulopathy, the acidosis, warm them up fully, get them stable enough for the next step.
Phase 4. Back to the OR for definitive repair.
Exactly. Once they're physiologically optimized, they go back for definitive surgery. This might take multiple trips over several days, and even then, if they start to decline, you back off, delay non-essential stuff.
Deciding who gets DCS sounds like a judgment call.
It is. There's no single magic number. It's a clinical decision based on multiple factors. Are they cold, coagulopathic, profoundly acidotic? Have they lost massive amounts of blood? Is the planned definitive operation going to be very long and complex? If they're circling the drain, you opt for damage control.
But the material warns against overusing it.
Yeah, absolutely. It's life-saving for the right patient. But using it on someone who could tolerate a definitive repair taxes resources, or our time, ICU beds. And multiple operations increase risks like hernias, fistulas, infection. Use it wisely.
And alongside DCS, there's DCR damage control resuscitation.
The medical strategy that goes hand in hand with the surgery. Key principles. Maybe permissive hypotension, lower blood pressure target temporarily, though tricky with long evacuation times. Definitely avoid large volumes of crystalloid fluids.
Focus on blood products instead.
Yes, hemostatic resuscitation. Using blood components early in ratios aiming to mimic whole blood to support clotting and oxygen delivery, and actively managing acute traumatic coagulopathy, ATC, which develops quickly after major injury. But critical point, none of this works if the bleeding isn't stopped surgically. You can't fill a leaky bucket indefinitely.
Given all this talk of hemorrhage, massive transfusion must be common.
Extremely common. Ideally, you stop the bleed first, but war injuries often demand huge amounts of blood products, fast.
And again, minimal crystalloid.
Strongly discouraged for exsanguinating patients. They don't carry oxygen, don't clot, just dilute everything. The perfect ratio of products is still debated, but most deployed units have massive transfusion protocols.
And following these protocols aggressively, especially in well-equipped Roll 3s, seems to improve outcomes.
Yes, provided you have that steady supply chain and sophisticated transfusion support. There's also a trend now to push blood products further forward, smaller amounts maybe, carried by medics or flight teams to roll one or two.
And future strategies, whole blood.
Potentially. Fresh whole blood walking blood banks or maybe novel alternatives to components. It's an area constantly evolving based on battlefield needs.
Decision-making is always key, but in these austere settings, it sounds incredibly pressured.
It's a different world compared to a well-resourced Role 3 where patient physiology is the main driver. In a basic Role 1 or 2, resource limits are stark.
Limited ORs, maybe no ICU beds, finite blood supply.
Exactly. Long evacuation times might make permissive hypertension too risky. Scarce resources like blood might need agonizing allocation decisions between patients. Sometimes getting the patient out quickly, even if not perfectly stable, is the right call because you just don't have the means to stabilize them further there.
These are incredibly tough calls.
And not something you just learn from books. The material stresses practice simulation, exercises, courses that replicate those pressures. You need to train for those impossible choices.
Okay, to really master this, you need to understand how the weapon affects, how bullets and blasts actually cause injury. Let's start with ballistics.
Firearms, yeah. Part of war since the 1300s. Basic idea. Explosion pushes projectile.
But the science is complex. Internal ballistics first, inside the gun.
Right. Hammer hits primer, ignites propellant, gas expands, pushes bullet, rifling spins it for stability.
Then external ballistics, bullet and flight.
Affected by ammo type, wind, gravity. Rifle rounds are designed for higher speed, longer range than pistol rounds. Different shape, more powder.
And the bullet itself matters material, shape.
Full metal jacket versus soft point or hollow point, for instance, affects penetration versus energy transfer and wound size.
But the critical part for surgeons, terminal ballistics, wound ballistics.
This is the interaction with tissue. Energy transfer. Military rounds usually have much higher kinetic energy mass times velocity squared, so velocity makes a huge difference.
Though the actual wound depends on range, angle, clothing, armor, anatomy.
Many factors modify it, but we describe the damage using two concepts, permanent and temporary cavity.
Permanent cavity is the actual hole.
Yes, direct tissue crushing and tearing from the bullet's passage. High-energy rounds might tumble or fragment, making this cavity larger, more ragged.
And the temporary cavity.
That's the shockwave effect. Rapid stretching of tissue outwards as energy transfers. It's temporary, but the damage depends on tissue elasticity.
Elastic tissues bounce back.
Skin, muscle, lung wall, they might stretch and recover okay from the temporary cavitation itself, but less elastic tissues.
Liver, brain, spleen.
They can shatter from that rapid stretch. And hollow organs with fluid. The fluid transmits the shockwave, causing them to burst. Understanding these two cavities is key. The figures illustrate it well.
And managing military gunshot wounds is different from civilian ones.
Generally, yes. Low-energy civilian wounds might sometimes be watched, but military wounds, higher energy, unpredictable temporary cavity damage, high contamination risk, they nearly always need surgical exploration. You can't assume the damage stops at the visible track. The figures show how far you might need to open things up.
So DCS if unstable, or maybe a planned second look later.
Exactly. Allow time for the full extent of tissue damage to declare itself. Now, moving to blast, the dominant mechanism recently.
And increasingly seen in civilian settings too.
Sadly, yes. Explosives rapidly release energy. Low explosives deflagrate, burn slower than sound, cause burns mainly. High explosives detonate supersonic shockwave.
Creating that blast over pressure wave, instant rise, slow decay.
The Friedlander curve, yeah. But in enclosed spaces, buildings, vehicles' reflections amplify and sustain the pressure. Much worse injuries.
Blast also throws fragments.
From the casing, added materials, or just environmental debris. These travel fast and can wound at distance. Shrapnel is the common term.
And IEDs are the characteristic weapon here, unpredictable.
Designed for asymmetric warfare, highly variable effects.
Blast injuries are classified into types.
5 types. Primary, secondary, tertiary, quaternary, quaternary. Helps understand the mechanisms.
Primary is from the overpressure wave itself.
Exactly. Unique to blast. Affects air-fluid interfaces most.
Like the eardrum tympanic membrane rupture? Most common.
Very common, yes. But importantly, its absence doesn't rule out other more serious primary blast injuries, like blast lung. Depends on the blast environment.
Blast lung sounds awful.
It's the most researched primary injury, and it's devastating. The shockwave directly damages lung tissue. Mechanism debated, spalling, implosion maybe. Severity relates to how fast the chest wall moves. Body armor helps reduce this direct effect.
Pathophysiology. Immediate slow heart rate, stop breathing, then bleeding into the lungs.
Alveolar capillary rupture, edema. Clinically, they often get progressively hypoxic hours later, can get pneumothorax, hemothorax, fistulas. Air embolism from fistulas is a major killer.
Diagnosis is clinical plus imaging, that bat wing look on X-ray.
Often, yes, CT is better. Treatment is supportive ventilation, being very careful about pressure and air embolism. Prophylactic chest tubes are controversial, and always assume other injuries if blast lung is present.
Abdominal primary blast, less common.
About 3% maybe. Overpressure wave causes damage at tissue-air interfaces. Hollow organs, especially the cecum, are vulnerable. Shear waves hit bowel and mesentery.
Presentation can be delayed.
Often, yes. Vague pain initially, maybe progressing to peritonitis if there's a perforation. Surgery is based on critical signs like blunt trauma. Findings range from bruising on the bowel wall to full thickness holes. Judging bowel viability is key. DCS with a planned relook is often needed.
Solid organs are tougher.
More resistant, yes. Parenchymal disruption is rare unless pressures are extreme. Bleeding can happen if attachments tear. Hard to distinguish from tertiary injury in enclosed spaces sometimes.
Okay. Secondary blast injury.
Caused by the fragments hitting the body. Major cause of wounds, potentially at long range, high velocity.
Wounds are irregular.
Very. Fragments tumble, creating unpredictable cavities and extensive damage. Management needs thorough debridement.
Considered dirty wounds.
Grossly contaminated. Septic principles apply. Serial debridement, delayed closure are the standard. Fragments usually only removed if easily accessible or causing specific problems.
Tertiary blast injury is being thrown.
Exactly. By the blast wind, it's essentially blunt trauma fractures, amputations, any blunt injury pattern.
And quaternary quinary are the extras.
Burns, smoke inhalation, toxic exposures, radiation, late infections, miscellaneous category.
And environment matters hugely. Enclosed spaces.
Increased primary blast, lung TM rupture, maybe decreased secondary fragmentation if shielded, but definitely increased tertiary blunt injuries from impacts inside.
Specific patterns exist, like under-vehicle blasts.
Yes, a distinct severe pattern. Blunt trauma plus solid blast injury shockwave through the floor. Causes severe foot, ankle, pelvic fractures. Mortality often from head injury or non-compressible torso hemorrhage aorta, liver.
And dismounted blasts. Soldiers on foot hit by IEDs.
Characteristic pattern.
Yeah.
Traumatic lower limb amputations, pelvic fractures, severe genital perineal rectal injuries. Horrific.
Main killer is hemorrhage again.
Massive, immediate hemorrhage. Initial management is all about bleeding control tourniquets, proximal vascular control surgically.
Rebo I mentioned as a potential future tool.
Resuscitative endovascular balloon occlusion of the aorta. Maybe a bridge to surgery for torso bleeding, but controversial due to ischemia risk with potentially long transport times, still being evaluated.
After bleeding control, it's serial operations.
Identify everything, especially in that complex pelvic region. Repair, debride dead tissue repeatedly, plan for delayed soft tissue reconstruction, external fixation for pelvic fractures, save as much limb length as possible.
Rectal injuries common and serious.
Very. Need careful exam, maybe proctoscopy. Often requires early colostomy for fecal diversion. GU injuries need careful assessment too, catheters. Wound exploration.
Complex multi-system trauma needing iterative care.
Constant reassessment, debridement, planning over days or weeks.
Okay, wrapping up the injury discussion, let's hit that persistent threat. Infection.
Fundamental to war surgery, battlefield wounds are just grossly contaminated by definition. High energy creates lots of dead tissue, especially blast, driving dirt, debris, clothing deep inside.
Wounding agents aren't sterile, fragments are dirty, delays make it worse.
Exactly. Contamination gets established. Organisms reflect the environment, skin bugs, gut bugs if relevant, hospital bugs later. Fungal infections are a risk in the very critically ill too.
So how do you fight it?
Starts at point of injury, maybe sterile dressing, antibiotics if evacuation is long, empiric antibiotics on arrival at hospital, but the absolute mainstay is surgery.
Debridement.
Prompt surgical control. Adequate debridement, removing all non-viable tissue. Drainage. Copious irrigation. But not high-pressure lavage that can spread bacteria. Gentle washing.
And wound closure.
Generally not closed initially, except maybe some face wounds. Leave open, pack moist, maybe use negative pressure therapy. Plan for delayed primary closure days later when it looks clean.
Tailor antibiotics later.
Based on cultures, yes. Tetanus shot always needed. It takes experience, good judgment, knowing how much to open, doing serial debridements, planning soft tissue coverage early.
Wait, look, repeat.
It's the cycle needed to prevent devastating deep infections.
Oh, okay. We have covered a massive amount of ground, this deep dive into conflict surgery. From the ancient history and ethics to the tiered care, evacuation, damage control, those specific devastating weapon effects, ballistics, blast, and fighting infection constantly.
Understanding all those pieces, the environment, the decision pressures, the physics of injury, the staged surgical approach, that's what gives you that elite professional level of insight you mentioned, seeing how it all connects.
It's a sobering look at how conflict, however terrible, has driven medical progress.
Necessity and the battlefield are powerful, if harsh, drivers of innovation.
And it leaves you, listener, with a really potent thought to consider. As warfare technology keeps evolving, drones, cyber, hypersonics, who knows what's next? How will injury patterns change again? And how must conflict surgery adapt, anticipate, and evolve just to keep saving lives on that constantly changing future battlefield?